Hello, my name is Jake Zipkin, and I'm a fourth-year medical student at Albany Medical College. In this project, we examine characteristics of recent interventional benign prostatic hyperplasia studies from ClinicalTrials.gov. Throughout this presentation, I plan to describe the project and its objectives, discuss the study design and how trials were identified on ClinicalTrials.gov, and examine and interpret the results. I will finish off by discussing the limitations of the study and next steps. While a variety of study designs provide helpful medical advancement, prospective and randomized clinical trials offer the highest grade evidence. Studies on benign prostatic hyperplasia, which I will hereafter refer to as BPH, are often single-center, retrospective studies with high attrition rates which yield studies with low-grade evidence and often unreproducible results. The U.S. National Library of Medicine maintains ClinicalTrials.gov to allow providers and patients access to prospective trials on a variety of diseases. In this study, we assess the similarities and differences in project outcomes, inclusion criteria, and exclusion criteria, as well as identify currently underrepresented patient populations to focus on in future research initiatives. Studies with an interventional research design and known study status were identified on ClinicalTrials.gov by searching the keywords benign prostatic hyperplasia and included in this project. We collected data from the first 100 studies listed in the search during the period of May 25, 2021 to April 13th. The search with the previously mentioned filters produced 396 BPH studies, of which we included the first 100 on the list. Median study enrollment was 111 patients, and mean duration of study was 904 days. Of studies captured, 63% were completed, 19% were active, and 18% were either terminated or withdrawn. International Prostate Symptom Score was the primary outcome in most studies, while number of adverse events, prostate-specific antigen level, and peak urine flow rate were much less frequently utilized. The most common secondary outcomes were peak urine flow rate, followed by post-void residual, prostate-specific antigen level, and prostate volume. A specific International Prostate Symptom Score was used for inclusion in 73% of studies, and the most common minimum score was 13. 48% of studies utilized a specific peak urinary flow rate for inclusion, with the most common maximum flow rate being 15 mL per second. All studies examined identified a minimum age for inclusion, with the most common minimum ages being 50 years followed by 45 years. Prostate volume was used for inclusion in 40%, and the most common minimum volume was 30 cc's. Minimum time experiencing lower urinary tract symptoms was used for inclusion in 32%, with a most common minimum of 6 months. A history or suspicion of cancer was the most commonly utilized exclusion criterion. In 50% of studies, undefined medical conditions as determined by researchers were used for exclusion. Other commonly used exclusion criteria included are listed on the slide. Overall, BPH studies on ClinicalTrials.gov utilize similar and common inclusion and exclusion criteria and outcomes. The homogeneity of these criteria and outcomes may limit the study of certain populations and reduce generalizability of results to patients outside of these criteria. There were several limitations to this study. First, we only examined interventional study designs with known study statuses. Second, we only included 25% of studies that were available based on our screening criteria at the time of data collection. Future steps include gathering data on additional BPH studies listed on ClinicalTrials.gov so we can better describe overall study characteristics. In addition, we plan to conduct univariable and multivariable logistic regression analyses to determine associations between trial characteristics while adjusting for confounding variables. Ultimately, these findings may help researchers to target specific patient populations in future BPH studies, thereby increasing representation of these patients in the literature. Thank you very much for your attention. If you have any questions, comments, or feedback, please contact me at the email address listed below.